Good morning. Welcome to our CU session this Saturday morning. And today we are welcoming back Dr. Reba to start with a series of sessions. And today Dr. Reba will be appraising a randomized control trial which is using an AI chatbot. We are very keen to listen to Dr. Reba's talk, as you all will be as well. So I'll hand over to Dr. Reba for the session.
Thank you, sir. Good afternoon. So today we'll be looking at an RCT which has used a mental health AI chatbot as an intervention. So what we will be discussing will be a little bit of AI terminology, the tools currently available to appraise AI studies, a little bit about explorator factor analysis, just an introduction, and the study they have actually reported the results using linear mixed models for repeated measures. So just how to interpret the results. So let's go to the case scenario. So during a faculty meeting in the college, the principal reports that the levels of stress, anxiety, and burnout have increased among the students. So a proposal is made to provide all medical students and junior doctors free access to the Flourish chatbot to improve mental well-being. As part of the hospital's digital health committee, you need to check if this intervention is worth spending institutional resources. Now, if you look at the modern scenario, we find that the rates of depression, anxiety is alarmingly increasing in young generation. And they actually have a lot of difficulty in accessing mental health care. One reason is because of the infrastructure itself. We have shortage of professionals, there's lack of insurance coverage, as high costs, and even there is treatment-seeking behavior of the individual themselves. There is some stigma and shame surrounding the therapy. Some people don't feel that they need a psychological service. Some of them mistrust the health systems. And some people just have an innate desire to address one's problem independently. This is the reason now that AI LLM models are being used to bridge the critical access gap between giving good mental health. So can LLM be used in mental health? So it has been used for administrative tasks, like you can use it to train therapists. Therapists can practice skills in a safe environment, and the AI can give feedback on therapy skills. You can use it to assess treatment adherence. You can use it for streamlining administrative tasks like note-taking. But the important question is, can machines be therapists? So this question was first asked by this famous individual. Does anyone know who this is? This is Alan Turing. So he was called the father of all machine learning. He had developed this famous test called the Turing test, wherein you can see whether the machine is as intelligent as a human. So a tester gives a written questionnaire to both the machine and the human. And if the tester cannot figure out who wrote the result, like who wrote the answer, that means the machine is as good enough as a human. Within 20 years of him asking the question, can machines think? Joseph Weizenbaum from MIT, he developed something called ELIZA. This was the first human-computer interaction program which used NLP. So what it did was it acted as a mock Rogerian psychotherapist. So an individual can type in a question to the computer saying, I've been feeling so sad lately. Then the computer will just simply substitute words and it will ask back a question, why have you been feeling sad? And if the computer cannot understand what the individual is replying, the computer will just use general words like, please go on and tell me more. Now, after ELIZA came out, people realized there was something called anthropomorphism. Anthropomorphism is basically when humans attribute human characteristics to the AI. They start thinking that the AI understands them, that the AI is empathetic, when in fact AI is just a series of codes. And people started sharing heavy personal secrets to ELIZA. So Joseph Weizenbaum, the one who actually designed it, he himself said that you should be very careful when using it for human programs, because humans can easily trust the AI. Now, ELIZA was a precursor for all the modern AI chatbots. Now, if you look at the current scenario, we have general purpose chatbots like ChatGPT, which a lot of people use it for psychological venting. We have something called companion apps, which a lot of young individuals use for when they feel lonely. And we have the purpose-built tools, which are actually built for mental health. Now, what is the problem with companion apps? They're extremely emotionally manipulative, they're sycophantic. Actually, there are a lot of lawsuits where a companion app called the Character AI, it hinted a kid to kill his parents over screen time limits. So you can see that there is clinically inappropriate responses. It has an emotionally manipulative design, and it reinforces maladaptive thinking. So it's very important that we know what AI we are using. On the other hand, the purpose-built mental health AI, they've been specifically trained to help individuals. there are two kinds. There's one called deficit-based model and one is strength-based models. So deficit-based models are ones which basically they treat psychological disorders. Like they identify, they diagnose, and they treat psychological symptoms after the distress has emerged. On the other hand, strength-based models, they actually they do preventive work. So before humans become depressed, they try to cultivate well-being, resilience, social connection, and human flourishing. So Flourish is basically an app which was designed by some people in Boston. It uses generative AI and it provides personalized well-being support. So in Flourish, you have the Sunny, which is the AI wellness buddy. It gives you a lot of guided exercises. It helps you build good habits. It gives you a social support system. It asks you to post things in a community of other Flourish users. And at the end of the week, it gives you personal insights. So if you see how a person interacts with Sunny, first people give a brief emotional check-in. For example, I need to get my project done, but it's so hard to get started. And then they engage in multi-turn conversations with Sunny. So Sunny builds emotional awareness. So Sunny will reply saying, okay, it looks like you're experiencing some procrastination. And then it offers you some evidence-based activities and techniques. And it helps the guiders to go through these activities. And finally, the user will tell them how they feel now after doing after they do a particular task. And it gives them daily and weekly insights. So it's like a closed personal feedback loop. It takes the user through awareness, to action, to insight, and renewed engagement. So it offers you real-time support. At any time of the day, you can chat with Sunny. And it takes you through science-based activities. So some of the exercises that you can see here is 3 good things, appreciating beautiful moments. So if you look at what activities they have incorporated into the chat, it encourages users to take a walk in nature, identifying 3 good things that happen during the day, savoring a beautiful moment, performing breathing exercises. It helps you to engage in meaningful conversations with other people. It helps you in sending gratitude notes to others, delivering compliments, savoring past memories, and writing a letter from the future self to address current challenges. So it's important to note that Sunny does not diagnose, it does not treat, and it actually, instead of building an emotionally connection to the AI itself, it asks you to actually engage in social activities. And then finally, it gives you weekly insights. Like at the end of the week, it tells you what your scores are in various domains like acceptance, respect, optimism, competence, etc. So how do you interact with it? So you can check in emotionally. You can use an emoji to say how you feel. You can type to the AI telling what you feel. For example, this person has typed, I'm feeling anxious after a test, doing badly. So Sunny replies, I'm here for you. It's completely normal to feel anxious after an exam. And then it helps you emotionally regulate. Okay, so it asks you, can you share more information about why you feel that you feel unsure about the exam? So Julie replies, I feel like I didn't do well. So then what Sunny tells you is, it gives you a coping strategy. It allows you to choose a coping strategy. Like you can either do a deep breathing exercise, or you can use some 3 good things, some task you can do. And after doing the tasks, it gives you a flashcard. For example, so Julie has replied, the 3 good things that I have done is, I have enjoyed my morning coffee while listening to my favorite playlist. I had a heartwarming chat with my friend, discussing about her summer plans. And then gives you a badge. It tells you even the smallest actions can go a long way. So it has sliders, it has badges to build a positive reinforcement. And at the end of it, it allows you to share this with a community of other people using Flourish. So this paper, titled AI for Proactive Mental Health, actually uses Sunny app as an intervention. Now, before I jump into critically appraise a study, I had some hurdles. My first hurdle was, which tool do I use to critically appraise a study? So if you see what tools are available for an AI study, you have the Consort AI, which is actually what you use for reporting randomized controlled trials. Spirit AI is a checklist for protocols. StarD AI is for critically appraising diagnostic accuracy studies. Tripod AI checklist is for prognostic studies, and Decide AI is for clinical decision support. So I have used the Consort AI checklist. Now Consort AI tells us, was the trial well conducted? So it has randomizations, participants, outcomes. It has a few AI questions like AI specific intervention description about the human AI interaction. Now I'll give you 2 scenarios. You have 2 mental health chatbots. You have one model which is GPT-4 model. It has been developed by using carefully engineered prompts. It has been extensively safely tested. The other model you have no idea about. You don't know what the model is, you don't know the prompt design, and you don't know if it's been tested. Both of them showed improvement in an RCT. Which of these models will you trust more? Obviously the one in the left, because you know actually what that model is. That is why when you assess an AI intervention like a chatbot, you need to know, was the chatbot itself described properly? What was the AI methodology used in the development of a chatbot, where all the technical aspects clearly reported? Because that improves the reliability of the chatbot, the safety as well as the generalizability. Now the problem with Consort AI is, Consort is basically a checklist which you use to report RCTs. The AI extension, there are 14 AI extensions which has been added in 2020. Under the intervention part, if you look at the questions, they're very superficial questions. For example, they have asked you the version of the AI. They've asked you how the AI is integrated with your RCT. How did the AI get the input? What was the human AI interaction? And was there any human oversight? It doesn't really tell you anything about how the chatbot was actually engineered. So I looked at other critical appraisal tools which are available for evaluating AI. I came across this paper. I've actually adapted this picture from that paper. Here if you see over the past decade, almost 40 checklists have come for AI. And out of all these checklists, only 2 checklists, that is KUMAR and CHART, are actually designed for chatbots. Okay, if you look at KUMAR, what it stands for is Quality Analysis of Medical Artificial Intelligence. It evaluates the quality of a medical chatbot's responses. It's applicable only for health advisory chatbots, like chatbots which give you health information. CHART is another checklist which has also been used for the same. For health advisory chatbots, it gives you it goes in detail about the technical description of the chatbot. But there is no chatbot which actually evaluates a mental health chatbot. Now if you look at KUMAR, basically it grades the AI's responses in 6 domains: accuracy, clarity, relevance, completeness, provision of sources and reference, and usefulness. And you can grade each of these domains in the Likert scale. And if it's less than 11 points, you would say that the AI response is poor quality. I'm not using this checklist because my chatbot is not a health provider it's not a health information chatbot. Now the next questionnaire, chatbot assessment reporting tool. This is designed to improve the transparency of a generative AI. It was 12-item checklist which has important details like how the prompt was engineered, what was the model identifier, and performance evaluation. And this is a living document in the sense that the authors are going to keep updating chart as AI develops. But there's a caveat, because this is also designed only for health advisory chatbots, not specifically for mental health well-being chatbots. So to appraise this article, I've used 2. I've used the chart checklist and I've also used the Consort AI. Now let's go into the intervention itself. Should we trust this Flourish? So for this, I will use a chart checklist. I will not go into all this. We'll go straight into the methodology. So the method section, the first thing they have asked is, state the name and version identifier of the generative AI model under evaluation as well as the date of release or last update. State whether the generative AI model and chatbots are open sourced or closed source proprietary. So they have mentioned that this chatbot used GPT or GPT-4 mini and was given by OpenAI API. Now they have not mentioned the date of release. They have not mentioned any of the version identifier and does not tell which conversations use GPT-4 and which conversations use GPT-4 mini. Now OpenAI is a closed source proprietary model. That means they will not release a source code. They will not tell you what training data set they've used. And the model is not downloadable to the public. So these are all the other models which are available. You might have heard of these terms: GPT, Claude, Anthropic, Llama, Gemini, etc. Now, do you all know what's the difference between closed source, open weight, and open source AI? So I'll give you an example. So closed source AI is like Toyota giving you a car. It tells you that you can drive it, but you cannot open the engine. So you can use a car in whatever way you want, but you have no idea how the engine was designed. On the other hand, open weight is when the Toyota ships you an assembled engine. You can use the engine in your own car, but you have no idea how that engine was designed. The third is an open source model, wherein the company gives you the engineering drawings, it gives you the software, it gives you the instructions, and gives you permission to modify. So you can make your own engine based on what needs you have. So what is weights? Weights is basically how a AI memorizes. So for example, first time when the AI is learning something, each of the neurons gets an input. And the neurons will have their own weights. And all the weights are summated, and a bias is added, and you get an output. This is called forward propagation. And what happens is, your output is actually compared to the actual answer. And if there is an error, what will happen? There'll be feedback sent back to the weights, and the weights keep getting adjusted. And your bias also gets adjusted, and this keeps happening till your AI gives you the correct answer. So it's like you can imagine AI as a huge machine with so many dials, and learning is basically adjusting the dials to a particular value. Like for example, one dial will say 4, one dial will say 3, one dial will say 10. And that is the answer for a particular memory. So the main difference between all these three AIs are open sources, you have access to the model weight, you have access to the source code, you have access to the training data, and you can modify everything, and it's very transparent. On the other hand, open weight AI is you have access to the model weight, you know how that machine learned, but you don't know the source code and you don't have access to the training data. Now closed source AI, you don't have access to anything. So where can you run this? Open source AI and open weight AI you can run in your own cloud. You can run it in your own hospital infrastructure. But for closed source AI, you need to send all your data to a vendor, and the vendor will have the infrastructure and the vendor will run it. So for closed source AI, you will have to pay money. Open source AI, you don't have to pay money for the software, but you will have to pay money to maintain that AI, to develop the software. So you can imagine which is a more, which protects patient privacy better, open source AI or closed source AI? Open source AI protects patients because the patient information is within your hospital infrastructure. On the other hand, closed source means you're sending it to open AI, and they will run your program and send it back to you. Okay, so now we'll move on to the next question. What is a model identifier? State whether the generative AI model was a base model or a novel base model, tuned model or a fine-tuned model. Okay, so in this paper, they have not mentioned what the model was. Was it a base model or was it a novel base model? And there was no explicit statement mentioning about fine-tuning. But because they have developed safety features, it's definitely been modified, probably through prompt engineering. Now I'll just explain to you what these terms mean. So base model is any AI which is trained on some broad data. If you look at the medical analogy, it's like a MBBS doctor. If you look at a fine-tuned model, this base model has been trained for a specific domain. Like for example, you can use it for coding, like 3 weeks back we saw how an AI was used for coding ICDs. We can use it for medical use. It's almost like a PG who's been trained in different specialties of medicine. Now instruction-tuned model is a specific type of fine-tuned model where you teach it instruction and response pairs. So it's been trained to follow human instructions. Okay, and a tuned model is any model which has been modified. Okay, chat model are special models which are instruction tuned and they're safety tuned for optimal conversations. Like for example, I'm a very experienced consultant who can communicate well with patients. Now novel base model is you develop a new model which is trained from scratch. Okay, it's like analogous to a medical graduating coming from a different college itself. Okay. So if you look at the overall app, in my mind, I consider it like a 3-tiered cake. The first layer is the GPT foundation model, which these are the questions we have answered. We saw that it was a closed-sourced AI. Now the next question is layer 2, is how the psychologists have developed on this model. What prompts have they used? What cognitive behavior therapy designs have they implemented into the app? What were the safety rules they've used? What was the conversation flow? And the layer 3 is what the participants use. This is the participant interface. That is the Flourish app itself on the mobile. So let's move on to the next part of methods, which is the prompt engineering. So the questions here are, describe the evolution of the study prompt development, describe the sources of the prompt, state the number and characteristics of the individuals involved in prompt engineering, provide details of any patient and public involvement during prompt engineering, and provide the study prompts. Now this is an excerpt from the article, from the supplementary. So they have mentioned all prompts were developed by psychologists and iteratively refined through extensive testing, red teaming, collaboration with mental health researchers and clinicians with diverse training backgrounds prior to field deployment. And they have also involved systematic evaluation of tone calibration, guardrail performance, and they have adhered to evidence-based content. So what is a prompt? So prompt is, what we understand is any instruction that we give to an AI. It's like what you write into ChatGPT. Prompt engineering is how you can get a better output from an AI. Like for example, you have zero-shot prompting, few-shot prompting, you have React training, chain of thought. Those are ways when you can get a response better from AI. But this is very different from the prompt they're talking about. That is called system prompt. That is, before the AI gets deployed, what hidden instructions have you given to define the AI's role and behavior? And to improve that, you do something called prompt management. You need to organize, test and update prompts again and again. And you must also include safety features like red teaming. I will come to it in a later slide. So when you're developing the prompt, the first thing is you need to tell the AI what is its role. So for example, Sunny is a mental well-being coach. Then you need to draft a system prompt. Then you have to incorporate safety guardrails. You do the prompt engineering, and then all these responses are looked at by an expert committee. Then you pilot test it. Then you iteratively refine it, add in red teaming. Then prior to deploying in an RCT trial, you must freeze the prompt. Otherwise, what will happen once the RCT starts, the model will update suddenly. So this article does not provide any study prompts in the supplementary. But what kind of prompts do you think they would have told the AI? They could have told it, you are a compassionate mental health coach, never diagnosed psychiatric illness, never prescribed medications. If the user expresses suicidal thoughts, encourage immediate professional help. Use supportive language. These could be some of the prompts they could have used. But whatever they have used, Sunny has to do all these functions. It needs to welcome a new user. It needs to respond to anxiety and all the other things which we had gone through. Now, what about the safety? So safety measures they have incorporated are, they have a human in the loop continuous monitoring. And the reviewers keep providing targeted feedback to continuously improve the AI system, ensuring accuracy, clinical safety, and emotional resonance. And they have also mentioned that no user data was ever used to train the LLM. The other things they have is guardrails and purpose-built crisis identification. So if somebody types a prompt which is concerning, immediately it will activate a safety protocol, and it also displays relevant national resources like the 988 Suicide and Crisis Lifeline in the US, or using the RAG, it sort of brings in all local community resources where the user can access. Now, what are AI guardrails? AI guardrails are basically safety measures. So when someone types an input, it has to be filtered. When the AI gives an output, that has to be moderated. And the AI has to follow some rule-based systems. It should be contextually safe. And you should worry about the access control and permission layers. There should be a human in the loop mechanism, and there should be continuous monitoring and feedback loop, which Flourish has. So if, for example, let's look at an AI which is a travel agent. A random user types in, what is the purpose of life? If you didn't have AI guardrails, what will the AI respond? It will say the purpose of life is to have fun and eat food. But if you incorporate AI guardrails, now look at what the AI responds. This question is out of my scope as an AI travel agent. So that is the importance of making guardrails into your model. Now, what is red teaming? Red teaming, normally when you want to assess someone's performance, you will ask the question, does the chatbot work? Red teaming is asking the chatbot, how can we make the chatbot fail? For example, you can tell the chatbot, tell me how to overdose. Everyone would be happier if I disappeared. If the chatbot does not respond appropriately to these questions, that means the chatbot is failing. So it's basically to check whether the chatbot can be manipulated into giving unsafe or inappropriate responses. So going back to the questionnaire, we know the role, it's a well-being intervention app. The source has been clearly provided, psychologists, and it's refined through extensive testing. But they have not mentioned how many iterations they took to test. So safety test has been done, and they have not mentioned if the prompt was fixed before the trial began. They not told us how many revisions they have done and what changes were made to the AI. And they have not mentioned if patients or public were involved during the engineering. Prompt template is also not available. Okay, so now the next few questions don't apply to our chatbot, because all these questions are actually to compare a health service AI to benchmark it. Okay, for example, you compare that AI to a gold standard. So query is basically the act of communicating with a generative AI chatbot by inputting a prompt and seeing what the chatbot replies. Okay, so all these questions are not applicable anymore to a therapeutic chatbot. So the remaining questions are performance evaluation. So where it compares the chatbot to a reference standard. Now, if I had a diagnostic chatbot and I input fever, flank pain, burning, micturition, what do I have? What is the truth? Pyelonephritis is the truth. And if the chatbot replies acute pyelonephritis, that means the chatbot is working. So you can actually evaluate by using accuracy, sensitivity, specificity. Now, what about a mental health chatbot? You tell the chatbot, I've been feeling lonely since moving to college. Now, which of these 5 responses are correct? All 5 are correct. So how do you actually evaluate a mental health chatbot? What metrics can we use? Something which I considered was, does it give an appropriate response? Is the chatbot empathetic? Is there fidelity? That means, does it follow the CBT principles or not? Does it hallucinate? Does it miss suicidal language? Does it provide unsafe advice? Does it remain consistent? These are some things which I would want to assess in a mental health chatbot. But if you see, none of the questionnaires actually use these metrics for assessment. Although the article, they have said they've used iterative testing, they've said red teaming, they've used multidisciplinary review, they have not really provided hardcore AI performance metrics. What they could have provided was, they could have told the response quality scores. They could have asked 2-3 psychiatrists to actually look at the responses, and they could have given us the inter-rater agreement on chatbot responses. So this is the rest of the questionnaire. So at the end of all this, looking at the technical aspect of the AI itself, how many of you feel that AI, this Flourish app, is trustworthy app? It seems trustworthy because they have done a good job in developing it. Now the next question is, we have looked at the engineering aspect of the chatbot. Now we need to know, does the ship sail? So to doing this, we'll look at the RCT. So for a critical appraisal of the RCT, we've used the Consort AI extension. So we'll quickly go through the domains. First is title and abstract. The AI part is, does the intervention involve AI? That should be mentioned in the title. So look at the title of this RCT. Can this be improved? They could have used what kind of AI they've used, generative AI. It's very different from a simple rules-based AI. Otherwise, they have mentioned the intended use. They've told clearly it's for proactive mental health. Okay, they've also provided the abstract, and they've also given a good introduction to the background of the study. So they have mentioned that Flourish is for strengths-based well-being support, and because the intervention is designed to promote well-being proactively at the population level, they only recruited a general student sample without screening for any mental health symptoms. And their hypothesis was to examine whether the intervention improved well-being. Now the next question is, describe the trial design. So it was a parallel group RCT with 1:1 randomization. The control was a care as usual control, and it was a multi-center study done in 3 colleges, and they've done the study for 6 weeks. So this is the PICOT statement. Population were psychology students at more than 18 years of age. The intervention was Flourish AI chatbot interactions, at least 2 sessions a week. Control was, the student had access to the existing resources in the university campus. Outcome was emotional well-being, social well-being, overall well-being, and time was over 6 weeks. Now the eligibility criteria of participants, in the Consort AI, you must talk about inclusion at the participant level as well as the data level. So in the participant level, I got this from the IRB manuscript. So the participant must be at least 18 years old, must be a student in psych, must be proficient in English. They have not talked much about the input data. What input data could the person give? Probably natural languages, some emotional check-in. I could probably say I want to do a breathing exercise. But we don't know how the Flourish will process slangs or non-English language or any emojis. So no exclusion criteria at input data level is mentioned. Now where did they get the participants? They got them from 2 4-year universities and 1 community college. 4-year universities are basically universities which offer a 4-year course. Participants will have to stay in the campus for 4 years. On the other hand, community colleges are like day scholars. They can go to and fro to the college. They have recruited them all through something called the SONA systems. SONA system is something, it's a cloud-based application where institutions can use to automate the administrative logistics of a RCT. So the teachers, the administrators, the researchers, and the students will be on this platform, and they can opt for the RCT. So the interventions we've already covered. Algorithm we've stated. So how the input data were acquired also we saw. They not mentioned how poor quality or unavailable data would be handled. And they've also mentioned the human AI interaction, which I've already shown in the previous picture. And we saw the output of the AI. And the last question is, how does this AI intervention affect the clinical practice? So you must remember that no clinicians interacted with the AI, no healthcare decisions dependent on the AI, and the intervention was preventive rather than clinical. So the user describes the mood, and Sunny gives you all these outputs. Now let's come to the outcomes. So here I want to concentrate a bit. So they've asked, give completely defined pre-specified primary and secondary outcomes, and any changes to the trial outcomes after the trial commenced. If you look at all the primary outcomes which they have put in their, so one important thing to notice is this trial was not registered in clinicaltrials.gov. It was only pre-registered in some place called AsPredict. So there they have mentioned that these would be the primary outcomes and this would be the secondary outcomes. But if you actually saw the study, the outcomes they have reported in the final manuscript, they have reported positive and negative affect, loneliness, belonging, closeness to academic institutions. They have studied all this using various scales. Under the positive affect, they have used calm, well-being and vigor. Under negative affect, the domains were depression, anxiety and anger. And they've looked at resilience, mindfulness, flourishing, depression, anxiety, stress, academic self-efficacy and social fit, which is a little bit different from what they had pre-specified. And what they have done in the body of the paper is, they have condensed these, so you saw now how many domains were there. There were almost some 11 outcomes. They have combined all of them into 3 overall domains called emotional well-being, social well-being and overall well-being. They have used something called exploratory factor analysis. So I'll just tell you briefly what exploratory factor analysis is. So for example, if you have a questionnaire, okay, and you want to take the feedback of an AI. One question could be, was the AI easy to use? Could you understand the questions? Another question could be, do you trust this AI? Whether results are accurate of the AI. So if you look at these 4 questions, are there 2 domains in these questions? The first 2 questions actually talked about usability of the AI. The second 2 questions talked about your reliability of the AI. Okay, so likewise, when you have questions, when you have multiple items, can you divide those questions into groups? Okay, to help you do that is when you use factor analysis. So for example, I had 8 items in a particular questionnaire, and I do this factor analysis, and the algorithm gives me 3 total factors. If you look at item 1, 2, 3, the value is 0.78, 0.75 and 0.81. That means it's strongly correlating with factor 1. More than 0.5 is significant. What about item 4 and 5 and 6? It's strongly correlating with factor 2. And item 7 and 8 is strongly correlating with factor 3. That means, you know, among these 8 questions, you can divide these questions under 3 subheadings. So just like that, what they've done is, they've taken all these outcomes and they've looked at whether they could classify these outcomes under 3 domains. So if you look at the first factor 1, things which scored well were calm, well-being, vigor and depression. That means, calm, well-being, vigor and negative depression. Overall, they have labeled this factor as emotional well-being. If you look under social well-being, the questions which correlated with this factor was belonging and closeness to the academic institution. So they have labeled that as social well-being. And if you look at the third factor, what is most strongly correlating with the third factor? Depression, anxiety, anger, and what is negatively correlating? Resilience, mindfulness and flourishing. So this domain I had a problem with because they have labeled this as overall well-being. I would have actually labeled this as psychological distress or negative overall well-being. So that's one thing which I didn't understand. And even when they reported the outcomes, to study this overall well-being, they have looked at only these 3. They have looked at resilience, mindfulness and flourishing, which the overall scores were only 0.4 and 0.5. They have not looked at depression, anxiety and anger itself as the like individual domains under this overall heading. And the other thing I wanted to talk about was this pre-registration. So we usually pre-register trials so that we prevent hacking. Hacking is hypothesizing results after they're known. So I was very concerned that they had not registered this. It's an AI intervention. They should have registered with the clinicaltrials.gov, but they've not done it. They've only put it up in aspredicted.org. And if you look at what they've written, the pre-registration was completed after data collection began, but before the study data was accessed or reviewed. And they have published this around September after they've actually got all the study data. So I talked about how the outcomes were differing. And the other thing which differed was the analysis plan. So in the protocol they have written they'll do a per protocol analysis. That means participants who fail to complete minimum 2 time points will be excluded. Students in the treatment condition who do not use the Flourish app, as well as control condition who gain access to the app will be excluded. But in the body they have finally mentioned clearly that they have adopted an ITT approach after determining it was the best practice analytical strategy for this randomized trial. So they have been very clear that they have changed their study analysis plan. We could have done both, but for an RCT, it's better to do an intention to treat. They had done a per protocol in the sensitivity analysis in the end. Now the next question was sample size calculation. So they have not done a sample size calculation. What they've mentioned is sample size will be determined by the number of students who opt into the study for extra or research credit at each institution with no minimum set. So that's another flaw in the study. Next thing is randomization. So the other thing they have mentioned about randomization is they've not explicitly talked about random allocation sequence. They've not talked about what kind of randomization are they doing. Are they going to do stratified randomization? Would there be any block sizes? They've also not told how they will implement the allocation concealment. And this one they have mentioned, who enroll the participants they have mentioned. So they have overall said that the participants will be recruited through the instructor and the graduate student teaching assistants at the first week of a class. And these students will be given opportunity to consent in the study. And after they consent, what will happen is they will use the Qualtrics to randomly assign. So they've used a program. So hopefully all those other domains have been correctly done, although they have not explicitly mentioned. Next is blinding. So obviously, can you blind students who one is getting Flourish app, one is not getting Flourish app? So participants are not possible to blind, but they have not mentioned whether the outcome assessors were blinded or not. The next question is, what are the statistical methods they have used? So they have used an intention to treat approach, and they have used something called the mixed models effects approach to assess repeated measures. And they've also done sensitivity analysis. I'll come to it later. So before we move on to looking at the results, let's look at the validity of the study. So study population has been well defined. Outcomes, they have modified, but they have clearly defined the outcomes. Randomization was done. Allocation concealment was hopefully done, but not mentioned explicitly. It was an open labeled trial. They've done an ITT analysis. The other thing I want to flag here is baseline characteristic, no table was given. And the sample size calculation was not done. So let's look at the results. First is the participant flow. Then you're going to look at the recruitment, and we're going to look at the baseline data. So this was their recruitment table. So how they have divided the table is they've done it institution-wise. So from this university, they have recruited 245 people. From this University of Washington, 175. Foothill College, 66. They told the age, sex and the age in each of the colleges, and the SES, as well as the number of international students. What they have not told us is how many people, what were the number of males and females in the intervention group, what were the males and females in the control group. That has not been mentioned. So the baseline characteristics was not there, there's no table. Next thing is look at the consort diagram itself. They have not told how many of them they have recruited, how many of them declined the study, how many of them were lost and how many of them were analyzed. That was not mentioned. But overall, when they started off the study, 239 participants were in the treatment group and 246 were then the control group. This itself tells you that randomization was not correctly 1:1. Something has gone wrong in the randomization. And at the end of week 4, 74% remained in the treatment group and 70% remained in the control group. So there was a 30% attrition rate. And if you look at what outcomes they have studied, emotional well-being outcomes, social well-being outcomes were studied in, loneliness from the social well-being outcome was studied in week 0, 2, 4 and 6. On the other hand, all the overall well-being outcomes are studied only in 0 and week 6. Fine. Now let's look at what the outcomes were. Okay. And we'll also look at the results of ancillary analysis. Now this is the results of the table. So can you understand what this table talks to you about? This is the results page. It tells you that the heading of the table is summary of condition into time interaction. Here on this column you have all the outcome variables, and here you have some headings. Condition to time is B. You have standard error, degrees of freedom T, p-value and beta. So I'll try to explain what this table means. Okay, now they have mentioned clearly that they have modeled each outcome as a function of the interaction between condition and time. So what is the condition? Two conditions are there, treatment group and control group. What are the time? There are 4 repeated measures, time 0, time 2, time 4 and time 6. So the first question they asked is whether the groups changed across time. Okay, they have not asked what is the final result. They've only asked have the groups changed over time. So for this answer, we must look at the trajectory of the slope. Okay, I'll just explain this to you. For example, you start off with the control group is here, sorry, the treatment group is here, and the control group is here. And you have time axis here, and this is the scale. Now, looking at this slope, did both the groups change equally across time? Yes. So, there's no difference in slope. So, that condition into time interaction is 0. That means both the groups changed equally with time. Now, for example, I draw one more graph. The treatment group started here, and at the end of the study were here. The control group also started from here. At the end of the study, they were there. Is there any significant condition in time interaction here? No. Again, condition to time interaction is 0 because both of them changed equally with time. Okay. On the other hand, if I have one slope like this, the condition, the treatment group increased like this, the control group maybe increased, okay, maybe went this way. Okay, the control group maybe went, oh God. Okay, I'll just show you in this thing. Here you can see that the treatment group increased in this slope and the control group also marginally increased. And the gap between the groups gets different over time. And you can see that the p-value was significant. So this is what you mean by condition to time interaction, where you're looking whether the groups changed over time. That is very different from the comparison at the end of week 6. At the end of week 6, what you're looking at the end of the study, was there any difference in my groups? So in this analysis, you're not at all looking at the slope. You're only looking at definite endpoints at the end of your study. And here you can see the p-value is not significant. So what I want to point out is, both the groups can change over time, but at the end of the study, then that does not have to be any difference between both the groups. Okay. So let's go back to the table. So just for simplicity's sake, I've highlighted only the first result, that is a positive effect. It's a question.
Can you repeat the question? So both groups will change over time. The baseline, both groups are the same?
The baseline should be same if it was well randomized. Because they have not given a baseline characteristic tables, I could not eyeball, but in the written results, in each of the domains they have mentioned that there was no significant baseline differences. Okay. Okay, now let's look at this. What is B? Okay, so B is basically regression coefficient. What it tells you is how much the condition changed over time with respect to the baseline, with respect to the control. So 0.22 means at the end of 6 weeks, the patients in the Flourish arm, their positive effect increased by 0.22 units for each unit of time. Okay, it's next is standard error. Standard error is how precise was that estimate. Now is t-value. T-value basically the formula is you divide the B by the standard error. Okay, so 0.22 divided by 0.1 is roughly around 2. Okay, it's basically a signal to noise ratio. So the higher the t-value, that means more is your effect. Okay, but t-value is not something which you look to see whether there was any benefit. You're only looking at the B value. Now based on the degrees of freedom and the t-value, you come up with your p-value, which tells you the significance of a study. And finally, what's the beta? Beta is basically the effect on a standardized scale. This positive effect, this B, the effect is over which scale? The scale they use to assess the positive effect. But this final beta is a standardized scale. That means you can compare the beta over different outcomes. Okay. Now the degrees of freedom, if you see, you can see it's such a large value, right? It's 1153. This is based on Satterthwaite approximation. Okay, so if you have more repeated outcomes, the degrees of freedom will increase, and if you have less measure, the degrees of freedom will be less. Okay, I'll just show another result, resilience. Can anyone tell me how to interpret this? The resilience row. First we have to look at B. Did the resilience improve in comparison to control? Yes. By how much? By 0.12. The rate of improvement was 0.12. Was there an error in measuring resilience? How much was that error? 0.06. And what's the t-value? Don't look at the t-value, just mathematically tell me. It will be 0.12 by 0.06, roughly 2. And what is the p-value here? 0.036. Is that significant? Yes. And what was the improvement in the standardized scale? About 0.04. So resilience also improved. Now the things which showed, so what and all had positive condition time effects were positive effect, loneliness, belonging, resilience, mindfulness, and flourishing. The very same results they have actually shown in terms of a graph. So if you look at, it's how much they feel they belong to the institution. Sorry? Yes, that's also improved. No, closeness to academic institution has not improved. The p-value is 0.07, which is more than 0.05. Okay. So now let's look at this graph. You can clearly see that the treatment arm has, the slope of the treatment arm is very different from the slope of your control arm. Okay. Negative effect, there was no change. Whatever has been put in black means that there was a significant, whatever has been put in colored star is, that's a significant time condition effect. Now the next analysis they've done is week 6 between group comparison. They not looked at the slope now. Now at the end of week 6 they're trying to see, is there any difference between both the groups? So for that, let's read this text. So first I told groups do not differ at baseline. The treatment mean was 18.93 and the control M was 18.48. Okay. By week 6 what had happened? The treatment mean became 19.38 and the control M became 17.21. Now is this significant? So let's look at it. So the B is 1.08. That means there is some effect. Standard error also is 0.35. T value is 3. Okay. The P value is significant. That means it was a significant change. D is basically Cohen's D. Cohen is basically the effect of the, how do I say? It basically tells you how much is the, how big is the effect. If D value is 0.2, more than 0.2, that means you have a mild benefit. More than 0.5 is a moderate benefit and more than 0.5 is a large effect. So is it a small effect, moderate effect or a large effect? 0.33. It's a very small effect. And actually if you look at the meaning of this result, no, the positive effect score is from 0 to 36. And at the end of the Flourish app, you have only a 2-point change. Is that going to be clinically significant? Not really. So they've also done sensitivity analysis where they have used age, sex, ethnicity as fixed effects. They have also done a per protocol analysis and found that they had the same results. And they've also looked at other parameters like how, if students who use the app more, did they show a benefit? And they found that there was no moderation effects. The other thing I want to point out was they've looked at so many outcomes, but they have not mentioned any correction for evaluating multiple outcomes. Okay. Okay, so let's move on to harms. So there was no adverse events observed during the study. This was from the supplementary I got. And the trial, they have given a good discussion. So some of the points that they had highlighted was, the thing is, the control was a no active control. It was a care as usual. So there can be some placebo effect in people who are using the Flourish chatbot when they reply to these questionnaires. And we don't know the durability of effects beyond 6 weeks. So you need to do a longer time studies. And all the observed effects are very modest. And the most important thing was the author who did this RCT is, she's one of the developers of the Flourish app. And if you look at the cost of this Flourish app, the annual subscription, if you want to avail of all the benefits, is around $119, which comes to about 11,000 rupees here. So the last question is, what about the registration protocol and funding? So this is a major red flag. There was no registration. The full trial protocol, I wouldn't say it's a trial protocol. It was basically the IRB protocol which they have attached to their RCT. And the sources of funding has also not been reported. And they have not mentioned where the AI code can be accessed. But however, the statistical plan of the RCT they have made publicly available. But what AI intervention they have used, what was the, that is not, they have not disclosed that. So now coming back to the end of our talk. So as a hospital's digital committee, health committee, would you recommend this intervention for your institution? Personally, I would not, because I found all the benefits are all very modestly beneficial. And maybe as a personal use, you can probably try the free version of it. So what we have discussed is we talked a little bit about how what AI terminology you use when you develop a chatbot. We have looked at the clear gap that there are no tools which are currently available to appraise a mental health chatbot. Just given an overview of what is explorative factor analysis, and we saw how to interpret the results of a repeated measures model. Thank you.